Bismillahirrahmanirrahim. Hello everybody. A 39-year-old woman gravid 2 para 1 at 28 week of gestation come to the hospital due to painful uterine contraction for the past 4 hours accompanied by the passage of clear fluid from her vagina. She initiated prenatal care a week ago, and at that time an anatomy ultrasound revealed a fetus with anencephaly. The patient prior pregnancy was uncomplicated. She has no medical problem or previous surgeries. She does not use tobacco, alcohol, or illicit drug. Temperature 37, blood pressure is 100/60, pulse is 80 per minute. A sterile speculum examination show pooling of nitrogen positive fluid in the vagina. Digital examination show a cervix is 4 cm dilated and 80% effaced. Bedside ultrasound reveal anhydromnios and a fetus in a breech presentation. Fetal heart rate is normal. Tocometer show a contraction every 3 minutes. Which of the following is the best next step in management of this patient? Administer corticosteroid, administer magnesium sulfate, allow spontaneous vaginal delivery, immunoinfusion and tocolysis, cerclage placement, cesarean delivery. So first of all, this patient came to us at 28 week of gestation. Second, she having painful uterine contraction with the rupture of membrane. Third, on previous ultrasound, she having the fetus having anencephaly. This is a neural tube defect. Fourth, anencephaly she having and on digital examination the cervix is 4 cm dilated and 80% effaced. Bedside ultrasound revealed anhydromnios and the fetus is in breech presentation. So based on these forehand, what is the management option for this patient? Because this patient is in active stage of labor, she having the rupture of membrane and the painful contraction. So on such cases, we will go toward the option C, allow spontaneous vaginal delivery. Why allow spontaneous vaginal delivery? Because this fetus is suffering from anencephaly, and anencephaly is a lethal anomaly characterized by the failure of neural tube closure, which result in the absence of the cerebrum, thalamus, hypothalamus, and portion of the brain stem. Affected infant typically die within hours of birth. The primary principle behind labor management of patients with fetal anomalies is to minimize maternal morbidity and mortality. Vaginal delivery has a lowest risk of maternal complication, for example, hemorrhage, infection, injury, pulmonary embolism, and consequently is the delivery modality of choice. So the choice C is the correct one to decrease the maternal mortality and morbidity. Now come to the incorrect one, administer corticosteroid. So as we already know that antenatal corticosteroid are administered for premature delivery at less than 37 weeks of gestation to decrease the risk of fetal lung diseases. Choice B. Administer magnesium sulfate. So magnesium sulfate decrease the risk of cerebral palsy and infant or mother at risk for delivery at less than 32 weeks of gestation. Choice D. Immunoinfusion or tocolysis. So immunoinfusion is not indicated for anhydromnios, and tocolysis indicated for preterm labor with prolongation of pregnancy, which can improve neonatal outcomes, but it will not be beneficial for this patient. C. Cerclage placement. So cerclage placement is indicated in the management of cervical insufficiency, contraction, gestational age more than 24 weeks, and lethal fetal anomalies are contraindication to cerclage placement. Choice F, cesarean delivery. Cesarean delivery is not indicated for patient with fetal having lethal anomalies due to decreased risk of maternal mortality and morbidity. I will explain to you that why the choice C is the correct and allow spontaneous vaginal delivery. As we already know that this patient fetus having anencephaly, and which is the neural tube defect, and with the cerebrum, hypothalamus, and thalamus not developed. So in such cases, we will go toward the spontaneous vaginal delivery to decrease the maternal morbidity and mortality.